About a month ago, I had a Marine come into the clinic. He was getting ready to go to warrant school. When he walked in, he told me that his left shoulder hurt, his right hip hurt, and both of his knees hurt. But his primary concern was his shoulder. So when I sat him down, I asked him to reach up and overhead. His right arm shot straight up, and his left arm was about 20 to 30 degrees away from perfectly overhead. And when I asked him if that was painful, he said yes. When I said, "How long has this been going on for?" he said, "Over 3 years." And when you really think about that, that means that that shoulder pain has been going on for more than 1,000 days. This is a pattern that I see constantly with veterans and active duty service members. We adapt, we compensate, and we push through the pain until one day we can't lift our arms overhead, or until we can't roll over and sleep on that side without being woken up and being in a significant amount of pain. Or, more realistically, until we try to do a push-up and we realize that that shoulder is screaming at us and we can't do the same number of push-ups as we used to anymore, or maybe we can't even do one at all. Shoulder pain is the second most common complaint that I see from veterans and active duty members after the low back. And just like the low back, it's highly treatable if you address it properly. So today we're delving into veteran shoulder dysfunction, the anatomy, the causes, the assessments, and most importantly, how to fix it. I'm Dr. Hint, and this is Mission Ready Body. Welcome back. Last episode we tackled lower back pain, and today we're moving up the chain into the shoulders. But before we dive into what goes wrong, you need to understand how the shoulder works. Bear with me, this is not going to be a lengthy college level anatomy lesson, but it is going to address the basics and the fundamentals to help you understand why the shoulder is hurting and what we can do about it. The first thing we have to talk about is the shoulder complex. The shoulder isn't just one joint. It's actually a complex amalgamation of 4 different joints that are all working together. You have the glenohumeral joint, which is the ball and socket joint, the scapulothoracic joint, which is where your shoulder blade glides on the back of your ribcage, the acromioclavicular joint, or the AC joint, which is where your collarbone meets the top of your shoulder blade, and the sternoclavicular joint, which is where your collarbone meets your sternum. All 4 of these need to move properly for a healthy shoulder function. If one of those 4 joints is not working right, the others will compensate and you will over time develop pain. It's also important for us to realize that the shoulder is unique. It's one of the most mobile joints in the body. You can move your arm in almost any direction, overhead, behind, out to the side, rotating in and out. But here's the trade-off. Mobility comes at the cost of stability. Your hip joint is also a ball and socket joint, but it's much deeper than the shoulder, and that means it's inherently more stable. The shoulder joint is much more shallow. Think like a golf ball sitting on a tee. It's designed for movement, not stability. So how does it stay stable? Through the muscles and the tendons and the ligaments. The rotator cuff, if any of y'all say rotator cuff, I will correct you. It's rotator cuff. It is a group of 4 muscles that surround and stabilize the shoulder joint. It's the supraspinatus, the infraspinatus, the teres minor, and the subscapularis. The supraspinatus helps lift your arm to the side, think doing like a lateral raise. Infraspinatus helps rotate your arm outward, think like you're brushing crumbs off the top of a counter. The teres minor also helps rotate your arm outward, doing that same crumb brushing off of the counter motion. And the subscapularis brings your arm towards your stomach, almost like you're patting yourself on the stomach. These muscles work together to help keep that humerus, that ball, centered on the T while you move. When they're strong and functioning properly, the shoulder moves smoothly and pain-free. But when they're weak, overworked, tight, injured, so on, that's when problems begin to develop. The next thing we're going to talk about is the shoulder blade, the scapula. Your shoulder blade is the foundation of your shoulder. It needs to move properly. Upward rotation, downward rotation, protraction, retraction. If your shoulder blade doesn't move correctly, it throws off the entire shoulder complex. The rotator cuff can't function optimally, and you develop impingement, pain, and dysfunction. This matters because most shoulder pain isn't actually caused by the shoulder joint itself. It's caused by weak rotator cuff muscles that can't stabilize the joint, poor scapular muscle and movement that throws off muscle mechanics, tight muscles in the chest and the front of the shoulder, like the biceps, weak muscles all across the upper back, and poor posture that shifts your head forward. And understanding this is critical because it tells us where we need to focus treatment, especially when you're in the clinic. When I find these things, it guides me directly to what sort of impairments I'm going to address. If you're just icing your shoulder and taking ibuprofen and trying to push through, you are never going to address the root cause. So, how does military service destroy our shoulders? Factor one is heavy gear and asymmetric loading. When you think about what you carried during service, we had body armor, rucksacks, weapons, ammo cans, equipment, all the above. All of these were mostly awkward loads, and all of this compresses the shoulder joint, pulling the shoulder blades down and forward and creating chronic strain on the rotator cuff muscles. Often, this is asymmetric, meaning that you're carrying more weight on one side than the other. Maybe the radio is on one side. Maybe you're carrying your weapon on one side and an ammo can on the other, but it's an uneven distribution of weight. In fact, what I notice with most service members is when they are walking, they tend to carry things in their left hand. So the right hand is free to salute, and this creates chronic asymmetric loading of the left shoulder joint, for example. Something that simple, done over miles, over days, over years, can definitely eventually become shoulder issues. The next factor is almost always overhead work. And that's because military work involves a lot of overhead activity, such as loading and unloading gear, working on vehicles or equipment, setting up tents and shelters, lifting objects overhead, getting smoked for doing something stupid. Repetitive overhead work, especially with fatigue and poor form, will wear down the rotator cuff tendons, and over time this can lead to tendinitis and tears. Another thing, body armor and restricted movement. When wearing body armor, it restricts our shoulder range of motion, just like rucking. The plates limit how much you can move your arms overhead and how far you can reach behind you. And when you wear it for hours or days, especially if you're on gate duty, your body adapts to this restricted position. Your chest muscles get tight, your shoulders round forward, and your shoulder blades lose their mobility. When you take the armor off, your body is not going to automatically reset. It's gotten used to a new normal, and now you're left with restricted motion because of these patterns and muscle imbalances. Another factor is PT culture. The military PT emphasizes pull-ups, push-ups, and overhead pressing. Done with good form and adequate recovery, these are fantastic. Done with poor form, because Sergeant Major wants to smoke you all, with inadequate rest, high volume, and high weight, often leads to beating up your shoulders and increased wear and tear. How many push-ups have you done in your life with your elbows flared out to the side because you just wanted to get the perfect score? That position is pathological, and it jams the shoulder joint and irritates the rotator cuff. How many pull-ups did you do while you were fatigued, shrugging your shoulders up as high as possible just to squeeze out that last pull-up or chin-up? That overloads the rotator cuff and the upper traps. Things like this done over and over again because we're told to complete the task and complete the mission to get the highest score possible can become pathological because no one took the time to teach us the right form. Another factor, of course, is sleeping in awkward positions, because every time you're sleeping in the vehicle or in a fighting position or out on the ground in body armor, you're not getting adequate quality of sleep, and you're sleeping in positions that often compress the shoulder. And over time, this can, of course, create chronic irritation and inflammation. And finally, and most common sense, injury and push-through mentality. Once you've injured your shoulder and you decide to keep pushing on through, you know that you're going to eventually pay the price for that. But most of the time, when we're injured, it's hard to get into physical therapy. It's hard to get seen by the doctor, and we can't take time off, so the mission must go on. So we have to push through, we have to compensate, and we have to adapt. And even after we heal, our body has now learned a dysfunctional movement pattern that helps us avoid pain, but whose patterns are going to cause pathology in the future. So the result is by the time that you get out, your shoulders have been subjected to years of compression and heavy loading, restricted movement patterns, muscle imbalances, poor scapular mechanics, overworked and potentially damaged rotator cuff muscles and tendons, and now chronic inflammation and poor sleep. And then one day when you go to reach for something off of a high shelf, you go to throw a ball with your kid or a football with your son or your daughter, you try to do that workout and try to do that extra push-up, the shoulder just says, nope, not happening. And that is the veteran shoulder story, unfortunately. So now let's talk about the types of shoulder issues. Not all shoulder pain is the same. Let me break down some of the most common shoulder problems that I see in the clinic amongst veterans and active duty service members. The first is rotator cuff tendinitis or tendinopathy. This is where the rotator cuff tendons become inflamed and irritated from overuse, repetitive stress, and bad mechanics. It feels like dull, aching pain in the shoulder, pain with overhead reaching or lifting, weakness when lifting the arm to the side or out in front, pain that's worse at night, especially when you're laying on that side, and sometimes it comes with a catching or a clicking sensation. I'll also say here that the dull aching pain in the shoulder a lot of the times is out on the outside of the shoulder and sometimes just in the back of the shoulder. Many people are surprised to find that the pain that they're feeling from a muscle is actually radiating somewhere else. So when they point to the outside of their shoulder saying this is where the pain is, that's actually where the tendon connects. A lot of the times, though, the muscle itself wrapped around the back of the shoulder on the back of the shoulder blade is actually where they're going to be tender whether they know it or not. So don't be surprised that this dull achiness kind of wraps around the entire shoulder and it's not very precise and you can't really point exactly to where it is. It can be diffuse and it can be hard to explain. Most of the time, you're going to feel it most acutely where that tendon connects on the outside of the shoulder. So what causes tendinopathy and tendinitis? Repetitive overhead activities, poor posture and poor shoulder positioning, weakness of those muscles, tightness of those muscles, and impingement. But the good news is that with proper conservative treatments, notably physical therapy, most rotator cuff tendinitis and tendinopathy resolves within 6 to 12 weeks. The second one is shoulder impingement syndrome. This is where the rotator cuff tendons get pinched between the bones of the shoulder. That would be the head of the humerus and the acromion, which is a bone coming up, wrapping around the back of your shoulder blade up to where your clavicle connects to it. This feels like pain when you're lifting your arm, almost in a jumping jack position. It also causes pain with overhead reaching, weakness and loss of range of motion, pain that improves when you lower your arm back down and have it by your side. What causes it is poor scapular mechanics because of weak shoulder blade muscles and weak rotator cuff muscles, as well as tight chest and front shoulder muscles like the bicep. What can also cause it, though, is things like bone spurs and arthritis of the AC joint. With physical therapy, this also has a very good prognosis. Surgery is rarely needed unless there's some sort of structural issue going on at the AC joint itself. Next, rotator cuff tears. The rotator cuff tendons can partially or completely tear, either from acute injury or gradual degeneration. A complete tear usually means that you're not going to be able to move your arm up and overhead at all. A partial tear means you can complete that task, but you're going to have increased pain. So for a partial tear, that means that some of the fibers are torn, but it's not completely ruptured. Usually when you go and have an MRI, this will be reported to you as saying there is a certain millimeter by certain millimeter tear, and it's in this position, and it's type 3 or whatever. It's often caused by years of wear and tear. A full thickness tear means the tendon's completely torn, and that can be usually from an acute injury or just chronic degeneration where the shoulder finally gives up. What does it feel like? Significant pain, especially at night. Weakness when trying to lift or rotate the arm. Sometimes a popping sensation at the time of injury. So like if you slipped and fell off of a ladder and landed on that shoulder, there's a loud pop. That would be a good indication that something might have been torn. Difficulty with daily activities like reaching behind the back and reaching overhead. And having minimal pain, but significant weakness. What causes it is acute trauma, usually a fall, a heavy lift where you're trying to lift too hard and the shoulder just gave. Vehicle accidents are another mechanism of injury. And then chronic degeneration from years of overuse and or a combination of both. Now, I'm not going to lie, this is the most complex one. Many partial tears can be managed with physical therapy. Some require surgery. This is one where you definitely have to talk to your primary care provider and surgeon physical therapist because this is case dependent, person to person. Another type, arguably the most sneaky type, is bicep tendinitis. Now, you might think of the bicep as just your Popeye muscle where you go to flex and it's sitting right there on the forearm, not on the forearm, but on your arm, and it's like, welcome to the gun show. But the truth is that the bicep tendon actually runs all the way up and attaches to the very top of your shoulder, and it can become inflamed and irritated, and this becomes painful at the front of the shoulder, and it feels like it's almost in the shoulder joint. This also becomes painful with any overhead activities, any pain with rotating the arm, like think flipping pancakes over, opening a door with a doorknob, even trying to make a snow angel or doing like a jumping jack motion can become painful. And a lot of times it will also radiate pain down the front of the arm as well. What causes it? Repetitive overhead motions, shoulder instability and weakness, and it often occurs alongside rotator cuff issues because the bicep is effectively trying to work itself to death to make up for weakness and instability and poor movement mechanics because of other shoulder muscle tightness and weakness. But with physical therapy, excellent prognosis. Another one that's less common is frozen shoulder. A lot of people get diagnosed with this and it's not actually frozen shoulder. A lot of the times it's just inflamed rotator cuff muscles, tight muscles, things like that. True frozen shoulder is just where the shoulder capsule itself starts locking down. It feels like a profound loss of range of motion in all directions. It's basically frozen. Pain everywhere, and disproportionate pain to what you would expect when trying to move the arm. Difficulty with any daily activities. Reaching forward, side, backward, overhead, it doesn't matter. And the key with this one is it's a gradual onset, and it progressively gets worse. You will not wake up suddenly and have frozen shoulder. You will slowly, day by day, be realizing you just can't move your shoulder that much at all, and it will get worse and worse. What causes it? No one knows. It can happen following shoulder injury or surgery. It is most common in individuals with diabetes, and it can also happen from prolonged immobilization. It typically resolves on its own, but treatment gets you there much better. There's, in fact, a lot of really good recent research on using corticosteroid injections to help improve the pain and improve range of motion when done with physical therapy. This is definitely one you're going to have to talk to your primary care provider, your physical therapist about, and get a plan going forward because it is, again, case specific, person specific. Next, AC joint sprain or arthritis. The acromioclavicular joint, where the collarbone meets the shoulder blade, can become injured or arthritic. This is just going to feel like pain on the top of the shoulder. It's going to be tender when you go and touch that front of the shoulder where the bones meet. It's going to be pain when you're trying to reach across your body and scratch your other shoulder. And it's going to be pain with overhead pressing. What causes it? A lot of times trauma because it's a sprain, right? But if it's arthritis, a lot of times it's just chronic age-related degeneration. But don't forget, like we talked about last time, your average veteran, their biological age may be 20 to 30, but their body's wear and tear is 10 to 15 years more on top of that. So if you're 20 years old, you might present like a 30 to 35-year-old in terms of how much wear and tear is on that joint. For AC joint sprain and arthritis, for mild sprains, really good prognosis. For arthritis, really good prognosis. For severe sprains and tears, obviously most of the time that requires surgery. And then finally we have scapular dyskinesis, also known as poor scapulothoracic rhythm. This is just where your shoulder blade isn't moving properly, which throws off your entire shoulder mechanics. This just feels like vague shoulder pain that's hard to pinpoint. It's this feeling that the shoulder isn't moving smoothly. It's like ratcheting, and it has a lot of clicking, a lot of popping, some grinding, and then you just get really tired with overhead motions because your muscles and your joint aren't working the way they're supposed to, so it's just much more fatiguing. What causes this? Weak scapular muscles, tight chest muscles, poor posture, And this one is my favorite one to treat in the clinic because people get better so much faster. So can you tell what shoulder injury you likely have? Well, you can go to a physical therapist and get screened. That's the best answer always. And you shouldn't be doing anything, any exercises, any sort of screening on the internet unless you've been cleared by a medical professional to do so. But if it was me with my physical therapy knowledge, here is how I would tackle this to say, okay, Dr. Hint, which type of shoulder pain are you having? Because it's one thing to know it from a textbook, it's a whole different thing to experience it. Well, if I'm having pain with a specific range of motion when I'm doing jumping jacks, for example, I'm thinking impingement, specifically from the middle arc of when I'm trying to do jumping jacks. If I'm having weakness with rotation, so if I'm trying to brush those crumbs off of the top of a counter, or I'm doing cable external rotation or internal rotation, and then I have increased pain at night, especially when I'm laying on that side, I'm thinking more rotator cuff. Most likely tendinitis, maybe some sort of tear. Pain at the front of the shoulder, radiating down into the front of my arm, I'm thinking more bicep. Pain at the top of my shoulder when I'm trying to reach across my body and scratch my opposite shoulder, I'm thinking, okay, that's more AC joint. Especially if I go and massage that area and it's really tender. If I can't move my arm at all and it's been going on for a few weeks, that's been getting worse, I'm thinking frozen shoulder. And if I'm trying to do any sort of push up or overhead press and my shoulder just feels unstable and it cracks and it pops and it clicks a lot and it just is exhausting, I can only do 10 pounds on one side and I can do 25 pounds on the other easy, I'm starting to think that maybe I have some sort of asymmetry or shoulder blade weakness. Most veterans, however, come in with a combination of all of these. It's rarely just one thing because usually you have that scapular dyskinesis in conjunction with impingement, in conjunction with bicep impingement. So sometimes people will walk into the clinic, which, like the gentleman that I was alluding to earlier, he actually walked in with all three. So it's not uncommon to have more than one, which is what makes this so confusing, which is again why I recommend going and see a physical therapist, because this is a hard one to tackle on your own because it's usually a trifecta of things and not just a one-off. So how would I do a shoulder self-assessment? Great question. I would begin with active range of motion. I would stand in front of a mirror and I would reach both arms up and overhead and then back down. I would check and make sure that I can get my hands just as high as the other. I would make sure that one's not significantly lower than the other. Then I would do a jumping jack motion without the jump. So I just take my arms out to the side, then up and overhead, try and get them to touch, seeing if one shoulder comes way far forward or if I have to shrug, or if one hand gets stuck because it's painful. Then I would do external rotation. So I'd have my arms out at my side, and I would do the SpongeBob SquarePants. I'd rotate my knuckles going down, and I'd rotate my knuckles coming up. So I'd do like a field goal position, and then I'd rotate at 180 degrees and do like the opposite of a field goal position. And again, I'm looking for any sort of asymmetry. I'm looking for any sort of pain. I'm looking for any sort of shrugging that I might be doing on one side versus the other. What does this tell me? If I'm having pain doing the jumping jack motion, it's likely due to impingement. If I'm having pain in all directions and I'm severely limited and I can barely move that shoulder at all, I'm thinking frozen shoulder or really bad tendinitis. If I'm limited and just bringing my arms up, doing like a field goal sort of motion, I'm thinking that I have really tight shoulders and I might have some sort of issue going on with the rotator cuff. And if I can't reach behind my back, I'm thinking that I have some sort of significant tightness and or weakness of the rotator cuff as well. If I'm doing that jumping jack motion and it's significantly painful, I'm thinking impingement, but if it's painful at the very top of the motion going up and overhead, I'm thinking it's more AC joint. The reason for that is when you're going through the jumping jack motion, several different muscles in the shoulder are taking over. In the beginning, it's your supraspinatus, then it becomes more your infraspinatus, then it becomes at the very top sometimes more of a joint restriction. So that's why if you're in the very beginning part of the motion and it's painful and it gets better in the middle, that would make me think supraspinatus. If it's painful in the middle of the arc, I'm thinking infraspinatus. And then if at the top of the motion I can barely get my arm up because it's really painful in the joint, I'm thinking AC joint. The next one is called the empty can test. That's where you raise your arm to the side, about 45 degrees, thumb pointing down, and you gently apply pressure on the wrist. If it's weak or if it's painful, I'm thinking it's a rotator cuff tendinitis, possibly a tear. And I would always compare this side to side. Um, for external rotation, the way that I do this, you can actually take a look at the YouTube channel. I anchor my elbow to the side of my body. I have my arm at 90 degrees right in front of me. Or sorry, I have my arm bent at my side, elbow anchored to my hip, and I try and brush the crumbs off the top of a counter into my other hand. So I have it trying to do that brushing motion into my own hand, and that allows me to assess for pain. Um, if I can't rotate it outward due to weakness or pain, I know that it's rotator cuff. And the specific muscle that I'd be thinking would be infraspinatus or teres minor. The opposite would be trying to bring that hand towards my stomach, like I'm patting myself in the stomach, and I resist that motion. That would make me think subscapularis if I was weak or painful. The next test I would do would be the one where I try and reach my arm across my body. I'm trying to take my, in this case, right thumb, reach across my body and have that right thumb scratch the outside of my left shoulder. If I'm having pain with that, I'm thinking it's likely impingement of the AC joint. Next, what I can do is I can take my phone and I can record my back, like taking a look at my shoulder blade as I reach overhead, as I reach out to the side, as I do rotations. Basically the same sort of tests that I talked about, which, by the way, all these you'll be able to find on Patreon for free, as long as you hop over there. I highly recommend joining. You'll be able to find all these tests that I'm talking about for free. And I'd be recording myself, taking a look at my shoulder blades, seeing how they move. If they're having any sort of issues where one's not moving the same as the other, I would take note of that. Some things that you should stop immediately and talk to a medical professional is if one shoulder blade is winging, and that's where the edge, the inside edge, has popped off of the rib cage, and now it's almost floating at like an angle, and it's popping, cracking, and ratcheting a lot. That is something to go and see a physical therapist or a doctor immediately about, because that's a sign that something neurological is usually going on. Any excessive shrugging of the shoulders, that's not good either. That could also be a neurological issue. And asymmetric movements, just meaning that you have some sort of dysrhythmia going on, a lot of times that requires a physical therapist to help correct. Next, you can do some shoulder flexibility tests where you're checking your range of motion. That's basically where you're trying to reach overhead and scratch in between your shoulder blades as far as you can by reaching overhead, and then you switch and you try and reach in between your shoulder blades, going up and underneath. One of them is called the Apley's scratch test. The other one is just, they call it, I think they call it the scratch test, where you try and reach up and from your low back going up towards your mid back, trying to scratch the opposite shoulder blade. The other thing that you can do that almost everybody should do is the doorway pec stretch. And that's basically where you use a doorway, you bring your arms up to 90 degrees, and then you step through, trying to stretch across the front of your shoulder. If you have any sort of significant tightness, it's usually the pecs, and the pecs play a pretty big role in shoulder dysfunction because they grab a hold of that shoulder blade and they pull it up and forward. The last test you can do is a push-up test, and that's just basically where you start doing a push-up against the wall, and you push your shoulder blades as far forward as you can. If you can do so smoothly with good motion in the shoulder blades, they don't pop, crack, or ratchet, that's good. If one shoulder blade is sticking out or moves really poorly, that's a sign that you have a weak serratus anterior, and that is a muscle that's critical for shoulder health. So putting it all together, using those tests, which you can find on the Patreon, you have a clear picture of if you have shoulder impingement, rotator cuff issues, AC joint problems, poor scapular movement known as scapular dyskinesis, or if you have any sort of restricted mobility. The red flags, again, these are the things where it's time to see a doctor: sudden severe shoulder pain after trauma, complete inability to lift your arm, significant issues or visible abnormality of one shoulder versus the other, numbness and tingling radiating down to your arm, pain that's getting progressively worse despite rest, and night pain that has been disrupting your sleep for more than 2 weeks. However, for most veterans, what we're dealing with is more impingement, rotator cuff tendinitis and tendinopathy, and scapular dyskinesis, and that is very treatable indeed. Now, we've assessed the shoulder. How do you fix it? Great question. If it was me, here's how I'm going to go after it. I'm going to go after mobility first, then stability, then strengthening, then fixing my posture. So the first thing I'm going to do is I'm going to stretch. I'm basically going to do yoga. I'm going to do my doorway pec stretches, 1 minute holds at least 3 times a day. At least 3 times a day. I'm going to do this sleeper stretch where I'm standing, elbow in front of me on the doorway, and I'm pushing my palm gently down towards the ground. Again, these are going to be things that you're going to be able to see on the YouTube. They're very hard to describe over the podcast format. I'm also going to be doing thread the needles, open books. And one of the most useful tools actually is whatever plane of motion I'm restricted in. Let's say that it's reaching overhead. Well, now I'm going to do wall slides. I'm going to take a towel, I'm going to hold that in my hand, and I'm going to slide my hand along the wall up as far as I can, and then back down. I'm going to go for no pain, but I'm just going to basically slide a towel up and down the wall 20 to 30 times. And that's going to be how I go for overhead. For out to the side, if it's the jumping jack motion, I'm going to do 20 to 30 in that direction too. All this is going to allow me to gently stretch my shoulder and build strength while just wiping down the walls. It's one of my favorite interventions to use early on for people that have issues. Next, I can do shoulder circles. That's where I'm going to take like a ball. I'm going to put it against the wall. I'm going to be standing arm width away from it, and I make clockwise and counterclockwise circles. And this is very, very, very tiring. I usually do it for time. I try and do like 15 seconds, then 30 seconds, then 45 seconds, then a minute, and I switch directions. So if I can only do 15 seconds, I take a break, then I do 15 seconds the other way. Then I do 30 seconds one way, 30 seconds the other way. All of this helps with mobility. But again, none of this is going to replace seeing a physical therapist because these are the things that they have to be able to see you in clinic to help fix. But again, for me, my routine, pec stretch every day, sleeper stretch as I need, thread the needles daily as much as I can, wall slides if I really need it. Shoulder circles are a great warm-up, but I like kettlebell halos and overhead presses, which you can find on the YouTube channel, which the link will be down in the description. All this again matters because mobility helps the shoulder have the range of motion that it needs. Restoring full range of motion takes pressure off the rotator cuff, the ligaments, and the tendons. And doing this every day for me is non-negotiable to keep my shoulders healthy. Next, I'd work on scapular stability because my shoulder blade needs to be able to move properly and be controlled by strong muscles. So, one thing I can do is scapular wall slides. That's where I stand with my back against the wall and I slide my arms up and down, focusing on squeezing the shoulder blades down and back into the wall as I move my arms up and overhead. And I like to do this for 3 sets of 20. I also like to do like face pulls, where I go to the gym, I grab the cable, and I pull the 2 ends of the rope to my armpits while squeezing the shoulder blades down and back. I like doing 2 sets of 20 with that as well. Prone Y raises are phenomenal. Laying down on an inclined bench, chin on top of the backrest, and then making a Y, driving the shoulder blades up and forward and then down and back. So as the arms come up and over, making that like field goal position, I'm driving my shoulder blades down and back towards my spine. 3 sets of 8 to 10 repetitions is what I usually do with a little bit of load. I'm not going to lie, it took me 2 months of doing this on my left side before I was able to lift a 5-pound dumbbell. These are brutal, but they are amazing for strengthening lower trap, which can be a muscle that is pathogenic in a lot of these conditions we've been talking about. Prone T-raise, exactly what it sounds like. It's like a reverse fly. You're laying down and you're squeezing those shoulder blades back as you pull the arms apart, making a T. You can also use the reverse fly machine. That's what I do personally. I do 5 sets of 10, which I think is a little bit ridiculous, but it's because I never want my shoulder pain and my left pec pain to come back, so I overtrain my back in that case. But generally, it's recommended you do 3 sets of 12. And this helps strengthen your mid-traps and your rhomboids, which helps deal with the tight pecs. But all this is important because it's assuming that I'm stretching the pecs. If I'm not stretching the pecs are going to be a very strong dominant muscle group that's going to try and override these guys. So unless I'm stretching the pecs every day, I'm not going to get the maximum benefit of doing these exercises. Next, you can also do the W raise. Of course, that's it's laying down, elbows bent, forearms up, and lifting. I don't do these ones as much because I don't need them as much. I just do the Ys and the Ts. Scapular push-ups, 3 sets of 10 to 15 for me. Start in a plank position, and all I'm doing is without bending my elbows, I'm treating my shoulders like a piston, pushing up and down, Again, 3 sets of, I think it was like 15 to 20. All of these are my favorite go-to exercises to prevent scapular dyskinesis or poor scapulothoracic rhythm. If my shoulder blade isn't moving right, my rotator cuff can't function properly, so I have to fix that foundation first. After that, it's moving into rotating the scapular, or strengthening the rotator cuff. So that's external rotations, internal rotations, empty can exercises, front raise, scapular raise, tons of rows. I'm already off to a good start with the prone T's, prone Y's, and face pulls. Now I'm just strengthening all my rotator cuffs. I do cable external rotations every shoulder day, 3 sets of at least 10. Sometimes I'll try and sneak in a 4th set. This for me, non-negotiable. It's too important for my shoulder health to skip. Internal rotations, I'm not going to lie. Sometimes I skip those because I'm doing lat pull downs and pec flies, so I don't need to do that much shoulder internal rotation. But if I was, I'd be using the cable machine for both of these, and I'd be doing, again, 3 sets of 10 in each direction, at least. Sometimes, like I said, I even sneak in a 4th set. Empty can, that's where I'm basically doing a scaption raise. So my arms are at 45 degrees, thumbs pointed down, while I have like 5 pounds in my hands, and I do that sort of raise. It looks ridiculous, but it's very important for strengthening the supraspinatus. And for these, I do 3 sets of 10 as well. And then rows, I do 5 sets of 10. I'm a psycho. I know you probably only have to do 3 sets of 10. That's all that I really do in the clinic. But for me, I do 5 sets of 10 of rows. And when I do that, I'm never, ever, ever, ever shrugging. With none of these exercises am I ever shrugging. I'm always pulling the shoulder blades down and back and then squeezing them together towards my spine. But all of these help me strengthen my rotator cuff muscles to prevent impingement. And I always start light and I build up. Overdoing it will make things worse. So I listen to my body and say, hey, if this is it, if this is what has to be the last set, even if it's only 2 sets, I'm calling it. It's not worth pushing through. And finally, I work on my posture. But most of that honestly comes from the exercises that I've done. But I do check my posture daily. Every single time I'm sitting down and taking a note, every time I'm sitting down and recording a podcast, I'm making sure that I'm sitting with my shoulder blades pulled down and back, chest open, to make sure that I'm not letting my shoulder blades squeeze up and forward and my neck come out. I also like to do what's called thoracic spine extensions, where I have a foam roller under my back and I do some thoracic extensions. Again, you can find those on the YouTube channel. Chin tucks are another phenomenal thing that I catch myself doing when I first wake up. And that's where I bring my chin straight back like I'm trying to bring it down to my spine, and then gently lift my head just an inch or two, and then bring it back down. And I do about 3 sets of 10 of those. They're brutal. I don't like them, but they're very important for my neck health. And then I also practice standing, what I call standing big, standing up, big, shoulders back, chest big, hips neutral, and then pulling the chin slightly back to make sure that I am not sticking my head really far out. All of this is important because it helps undo being hunched over a desk or looking down at my phone and tablet all day. And it helps break that cycle of dysfunctional posture that can be causing some of the shoulder pain and feeding into those bad posture loops. So putting it all together, what does it look like? 10 to 15 minutes of shoulder mobility work every morning. Monday, Wednesday, Friday, scapular strengthening routine, rotator cuff strengthening routine, and then throughout the day doing postural checks and chin tucks. That means total time weekly is 60 to 90 minutes of dedicated shoulder work plus daily mobility. Now, on a progression timeline, that means for the first 2 weeks, I'm focusing on mobility and gentle movement. And this is actually true mostly in the clinic. Most of the time for the first 2 weeks, sometimes even 3 weeks, I'm focusing on just getting people on getting their mobility back and making sure they're not pushing through pain. Then weeks 3 and 4, I'm really looking at adding in strengthening, looking for any sort of improved range of motion. By week 3 and 4, I should hopefully have mostly achieved normal range of motion with compared side to side. Weeks 5 and 6, now I'm really strengthening the rotator cuff because I have the range of motion back. My scapular muscles are getting stronger. Now it's good for me to go in there and start strengthening and encouraging good movement patterns for the rotator cuff muscles. And there should be very little to no pain. Weeks 7 to 8, I keep progressing to whatever limitations I'm seeing with a patient. By this point, they should have very little to almost no pain and much better range of motion and control. And then by weeks 9 through 12, it's like, okay, what do we have left? We probably have just a little bit of shoulder instability with a couple of muscles, and we're just going to keep loading those and strengthening. But that's typically what that progression timeline looks like for me in the clinic when I'm working with this patient population. The rules that I use, I start light because the rotator cuff is small and it can be easily overloaded. If any exercise is painful, I either skip it or I just make it body weight. So if doing external rotation with the cable is painful, with like 5 pounds, I'm not pushing through. I'm just going to go and do either isometrics or just body weight motions. Never, ever, ever do I have a patient work through sharp shooting pain or numbness and tingling. And I do, personally, when I work out my shoulders, if it's really hurting, I will ice it for about 15 minutes after. But the most important thing is to be patient, because shoulders do take longer to heal than most people think because of how it's that shallow joint. And there's so much muscles involved for that stability. So before we wrap up, let me tell you what not to do, because these are the mistakes that I see all the time. Ignoring it and pushing through. We've already talked about that. Only resting, expecting resting to make the problem better. That doesn't work for everything, because prolonged rest can increase weakness, increase muscle tightness and stiffness. That's why you should have to go to a physical therapist, because they're going to help you know how to move and how to stretch intelligently. Doing too much too soon. Everybody wants to go back to lifting like they were 18 and 20. Not a good idea. Starting heavy is never a good idea. Starting by overly aggressively stretching, never a good idea. The shoulder can flare up and be worse than before. So again, slow is smooth and smooth is fast. Light and slow progression is necessary. Next, some people want to completely neglect the back muscles. They think if they just focus on the pec and on the bicep, things will get better. But the truth is, you have to strengthen the entire rotator cuff and those muscles across the back of the shoulder blade to actually get true improvement. Also, everybody has bad form when it comes to shoulder exercises when they're coming from the military. It's just true. Going and seeing a physical therapist, there's really nothing to replace it, because they're going to correct your form. And that's going to help prevent you from having pathologies in the future. What to avoid, me personally, what do I avoid, is behind the neck presses, upright rows. I do seated cable rows, and I do machine rows, but I don't do like high face pull rows, not heavy. I do them light as a warm-up, and I pull down and back, squeezing my shoulder blades instead of pulling high and shrugging into them. Bench pressing or incline pressing with flared elbows, nope, not anymore. I used to. I don't do those anymore. I stop. If I'm starting to go into that pattern, I have too much weight on the bar. Dips, I've stopped. I will no longer do dips. After I strained my left pec minor so bad that it took me over a year to rehab, I went back to trying to do dips. It's not in the cards for me. The pain is not worth it. Heavy overhead loading with poor form. Again, once you start feeling your form fall apart, it's probably time to scale back. So, all of that being said, here's what I would do this week if I was having shoulder pain. I would do my shoulder assessment. I would go through and test and write down my findings. I would start a daily mobility routine on what I think I need to stretch, mostly my pecs, maybe my infraspinatus, do some thread the needles, do some wall slides. Again, all this is assuming you've been cleared to exercise by a medical professional. And I would do that mobility every single day for like 2 weeks to see if that improves my range of motion and if it reduces my pain. And then I would also start strengthening. I would look at my Ys, I would look at my Ts, I would look at my face pulls, I would look at my scapular push-ups, I would look at my rows, and then I would also set postural reminders where maybe every hour I'm checking my posture while I'm sitting there at work, making sure I'm not slumping into the world's worst posture ever. That is it for episode 6 of Mission Ready Body. Your shoulders carry the weight of your service, literally. Years of heavy gear, awkward loads, and repetitive stress left their mark. But shoulder pain does not have to be permanent. With the right approach, mobility, scapular stability, rotator cuff strengthening, and postural correction, it is possible to significantly reduce or eliminate pain and get back to the activities that we love. Giving yourself 8 to 12 weeks of consistent effort, tracking your progress, and if you're not seeing improvement, getting professional help. Again, this is all assuming that you've been seen and cleared to exercise by a medical professional. The goal here is not to wait 3 years like so many veterans and active duty service members do, but to address this early on to get better quicker, to get back to doing the things that you love. Next week, we're diving into knees, rucking, running, and reconditioning, addressing the lower extremity issues that plague so many veterans and active duty service members. If this episode helped you, please consider leaving a review on wherever you listen to it, liking, commenting, subscribing, and sharing. And also consider joining the Patreon, following on Instagram and YouTube and all the above, because that helps immensely with the algorithm. As always, the show notes, the assessment tests, and just general notes from this podcast episode will be available on Patreon for free, but you're going to have to click the link down below to follow it over there to see them. Remember, most of the time, the shoulders aren't broken permanently forever. They just need the right treatment. Everybody stay mission ready, and I will catch you all in the next episode.